everyone, welcome to this November meeting of the Shropshire Health and Wellbeing Board. The first item on the agenda is election of chair. Could I have a proposer for the election of Councillor Simon Jones, portfolio holder for adult social care and public health, please? Sorry, didn't have my microphone on, sorry. Welcome to this November meeting of the Shropshire Health and Wellbeing Board. The first item on the agenda is election of chair. Can I have a proposer for the election of Councillor Simon Jones, portfolio holder for adult social care and public health, please?
Happy to propose.
Thank you, Tanya. Tanya propose, and a second, please. Mark Brandreth. Thank you. Thank you both. I'll now take a vote on this. If I could just take a vote of the board members, raise of hands. Thank you, everybody. That's a raise of hands from everybody. And I'd now like to welcome Councillor Simon Jones as the new chair of the Shropshire Health and Wellbeing Board. And we're just going to get him now because he has to wait outside while we do the vote. Thanks, Simon. Simon, you've been duly elected as the chair. So I'd just like to welcome you to the board and hand the meeting over to you now. Thank you.
Thank you. Good morning and welcome to the meeting of the Health and Wellbeing Board. I'm Councillor Simon Jones, Chair of the Board. I'm obliged to inform you that this meeting is being live streamed and recorded. Members of the public will be able to see this meeting and hear the audio. The second item on the agenda is disclosable pecuniary interests. Members are reminded to disclose any pecuniary interests in any matters to be discussed, which is not included in the register of interests and leaving the meeting prior to the matter being discussed. Are there any such disclosures?
I'm a recipient of a grant through the Better Care Fund. So, I'm a recipient of funding through the Better Care Fund, my organisation, so I won't be able to vote or discuss.
Thank you. Next item, item 4, minutes of the previous meeting. I move that the minutes of the Health and Wellbeing Board meeting held on the 8th of July and the 9th of September, as circulated with the agenda papers, be signed as a correct record. Has anybody got any objections to the records being signed as correct? No, we're happy with those. Sorry. Sorry.
Rachel.
Oh, Rachel. Sorry. Yes, I forgot you there.
Apologies for joining you all on screen. I'm not able to be with you because of COVID, and I'm making sure that I don't join everybody until I've had a negative PCR result. So the wonders of COVID have kept me away from you all. It was just a comment on the notes, please, Chair, if I can. And under the Shrewsbury Health and Wellbeing Hub conversations, I just wondered if the notes could be amended to reflect my recollection of the conversations, where I'd asked that the report went to scrutiny, and I believe Claire Parker from the CCG had said that it would be going to the report would go to the scrutiny committee at an appropriate time, and also I'd asked impact assessment to be carried out, and I think that was where the response came back that there was an equality impact assessment being commissioned, but we would look at an integrated impact assessment. So if we could just reflect, if a change could be made to the notes, if that's for the recollection as well, just to reflect that, I would be grateful. Thank you.
Which set of minutes is Rachel referring to?
Yeah, which set of minutes is that you're referring to, Rachel?
Sorry, that was the last set of minutes for the last board, September.
9th of September.
Yeah.
Thank you.
Thank you.
Okay, thank you. So with that amendment, are we happy to sign it as a correct record? I move. So do we have a seconder? Seconder, yes. Thank you. All those in favour? Any against? That's fine. Thank you. Next item on the agenda is public question time, but my understanding is there are no public questions. Well, right, thank you. Then system update. Integrated Care System ICS update presentation by Nikki O'Connor.
Good morning.
Sorry, Mrs.
Apologies, I'm having awful Teams problems this morning, which is just what you want at the start of the day. So I can't get into anything that I might have sent to you before, but I've just thought perhaps it would be helpful if I talk a little bit about where we're up to in terms of setting up the ICS, a bit about roles and structure and governance, and then I'm happy to take any questions on all of that. And perhaps just to sort of start by saying, I suppose a bit of a recap really. So the reason that we're going in this direction, and not just us, obviously everybody in the country, is that the NHS was of course set up originally to deal with episodes of acute illness, to treat people and then hopefully send them home again. And as we continue, and as you've got other things to discuss on this agenda today, that model becomes less and less workable for us as we deal with people who've got long-term illnesses, as we deal with children who've got affected life chances, and it means that we need to work differently and much more closely together with local authorities and with other partners around the health of our population, around tackling health inequalities, and working beyond the NHS boundaries on things like the economic determinants of health. So where are we up to for our system? I suppose I'd reflect on the fact that the bill is still going through Parliament, so there's still things to happen around all of this, but fundamentally we are now in the process of creating what our new structure will look like from April next year, with a view to that structure being much more fit for purpose in dealing with some of the things that I've just mentioned. So we will have from the 1st of April an integrated care board and an integrated care partnership, and those two bodies together make up what we know of as an integrated care system. So our integrated care board will probably look different to what we have now in terms of our ICS board. It will be smaller, but the chair for us will be the same chair. So Sunil McKay will be the chair of that integrated care board. There will be non-executive directors on that board who will be new to the system. So those people cannot be people who are currently in a non-executive role in any of our current organisations. So we will have some new people coming in. We will also have some new executive directors. So within the current legislation, there are 4 mandated executive roles, and they are the chief executive, a director of nursing, a medical director, and a chief finance officer. And in addition to that, and this is something quite unusual and new, particularly in NHS terms, we will have what are called partner members, and for us, those partner members will be the 2 local authorities, a representative section of our provider organisations, and GP members, and that is how that board will be set up, and that is that is how it will make decisions across those 3 sections. I think we've also come to the conclusion for us that it's really important that we retain the history and knowledge that we have within our organisations, and therefore we are asking probably our chairs of the current provider organisations to chair some of the subcommittees of that board, so that they also become involved in the workings of the board. So that's the integrated care board, and we will also have an integrated care partnership, and that's probably of particular interest to this meeting. That is a much less mandated grouping of people. It will be chaired by the 2 local authority leaders. We will probably meet 2 or 3 times a year. It will have representatives from the integrated care board on that. It will have representatives from the local authorities, representatives from Health Watch, and it's for us to decide who else we might want on that board. I've worked in other places where the police sit on those sorts of arrangements, the fire service, because that's far more about the broader determinants of health than perhaps the Integrated Care Board itself will be. And the function, or one of the primary functions of the Integrated Care Partnership, is actually to set the integrated care strategy for the system. Sitting elsewhere in the system, and things you already know about in this meeting, we will have our 2 place-based arrangements, and they will link closely to yourselves in the Health and Wellbeing Board. And the place-based arrangements are largely focused on the population of those particular places, and around arranging provision of health care for the people in those populations. We will also have what's called a provider collaborative, which is where the providers in any given system can get together and decide what might be the best way of providing care, thinking beyond the boundaries of organisations themselves and linking up care so that it's more streamlined for patients. And then something that we are still developing within our system is the neighbourhood arrangements, which are centred around the primary care networks that we have, of which we have 8 in our system. And that is really about focusing multidisciplinary arrangements around individuals, around families, and making sure we can concentrate care in the right places for the right people. And I think I'm going to stop there. I think I've probably sent a bit of an update that was more broadly around some of the issues that are happening in the system, around vaccination, etc. But in terms of what I can bring to this meeting and in terms of my role, we are very focused at the moment on setting up our structure and governance so that we can enable the system to provide better care in future. So happy to pause at that point and answer any questions or comments.
Do we have any questions? Yes, Cecilia.
Thank you very much for that presentation. Could I just ask for a little bit more detail with regard to neighbourhood arrangements? When you're talking about a neighbourhood, what are you actually talking about here? Are you talking about a market town? Are you talking about perhaps arrangements that can be spread out, particularly in the rural areas, with some kind of spots in village halls, for example? What does neighbourhood mean in this particular context?
Okay, so I suppose the first thing would be to say that there's a fair amount of flexibility to design what we want it to be, but neighbourhoods are centred around populations of around 30 to 50,000 people, and around the primary care networks which are already in place across the system. But their purpose is to ensure good primary care provision, bringing multidisciplinary teams together, so that may be social workers, that might be GPs, that might be other providers of community services together to particularly focus on individuals and families who've got particularly complex needs. So it's there that neighbourhoods are there to really try and focus care in a multidisciplinary way, so not just GP services or not just social care services or district nursing services, but to focus the skills of those people around the needs of individuals.
Sorry.
Does that answer your question, or is that a bit too
esoteric? Sorry, at one level it does, but Chair, would you mind if I just came back for a quick follow-up? One of my particular concerns, I'm Councillor Cecilia Motley, by the way. I have, at the moment, I've got the portfolio for communities and culture and leisure. Communities is my particular concern in this particular instance, because I'm very conscious of the fact we are a very large county. We have a very large rural population in Shropshire, less so, I appreciate, in Telford, obviously. But what I'm concerned about is this issue of ability to access care in some of the rural areas. Because, as you know, anybody even having to access GP, primary care services in rural areas, sometimes finds that quite difficult because they have to travel quite a long way. If they're elderly, they may not necessarily have transport. They don't have public transport. They have to rely on other people to get them there. And that's why I'm really quite concerned to see that we try and build in some form of outreach into this, and actually break it down rather further than looking at, you know, I mean, when you talk about a neighbourhood, that is quite a large unit of population, if you like, that you're dealing with there. I'm talking about seeing if we cannot break that down further so that we can actually deliver services more effectively to the rural areas, instead of the rural areas always having to come to a central point. Do you see what I'm saying? And you know, as you're putting this together at this particular stage, I felt that this is something which should perhaps be fed in at this particular stage as well.
Yeah, absolutely agree with you on that. It is a particular challenge for this area. I suppose what we're trying to do at the moment is set the infrastructure in a way that can respond to those needs. Both of the place-based boards, as they currently sit and as they evolve, will need to take that on board as a particular issue for this area, and work with the neighbourhoods to ensure that we can provide better solutions for people. I mean, the best solution will always be trying to provide care in people's homes and not asking them to travel for services. There'll still be work we need to develop around that, but that will be the ethos, to provide care at people's living place as much as possible. There will obviously be occasions where people have got to travel if it's for something specialist, they need particular diagnostics, but the best place for people to be treated is in their own homes in the majority of the services that we provide.
Okay, thank you. Thank you, Chair. Sorry to have taken up so much of your time.
No, sorry, thank you. Tanya.
Thank you, Chair. So thank you, Nikki, for the update. I wanted to highlight the Health and Wellbeing Board and to members listening in today the COVID service in Shropshire for the weekend, and the fact that we are among the top performing regions in delivering the COVID vaccination to children aged 12 to 15, and to congratulate the team in that delivery. And it would be also helpful from a voucher perspective to give the highlights, Rachel, in terms of what we're currently doing in terms of that booster. It's great also that in Shropshire we know that we've got many adults and children now that have been vaccinated. But what is really important for all members and the public to hear is the importance of receiving a booster vaccination if you have reached your 6 months from your last second vaccine. Thank you.
Thank you, and I just say from the chair, I'm actually going for my booster on the 18th. So, right, did you? Yeah, Rachel, did you want to respond to that?
Yeah, I mean, I think just to add to that, it's obviously the vaccination programme, the flu and the COVID vaccination programmes are so important to our communities this winter. And I'll mention later in our item around the winter wellness campaign that we're launching, just to encourage people to ways of keeping well over winter. But as we said, the vaccination programme has been phenomenal across the county, but we need to keep getting the message out that people do need to come forward for their boosters. As Tanya's pointed out, I particularly just wanted to draw attention to some of the mobile bus work that will be going on, our Inequalities bus that I know was mentioned, particularly in the south of the county. So there is a focus because to ensure more access in the south of the county. So that if there will be a schedule that's coming out, our mobile bus will be back out, if everyone remembers that, our Inequalities bus that I know was mentioned in the paper, as a really important way of getting out to our communities across Shropshire, Telford and Wrekin, but particularly there'll be some events this week and over the next few weeks in the south of the county, again, to just improve access and make accessibility as easy as possible for people. So again, it's just that real key message about encouraging people to come forward and take up their vaccination. It is important after 6 months that we don't think it's great we've done our job. It is, but we need to keep going. That booster is absolutely essential. So thank you.
Yeah.
Thank you. Have we any further questions at all, Nikki? No. Right, well, the Health and Wellbeing Board has asked to receive the update, which was obviously accompanied by the slides that we've each got. Are we happy that we note and accept that update? Thank you. Right, moving on to Joint Commissioning Board. Laura Tyler, Assistant Director, Joint Commissioning. And if you'd like to speak to your paper, is Laura here or?
And Penny.
Oh, it's Penny.
I'm here.
I was on the screen, yeah. Sorry, I can see Laura. Yeah.
Morning all. Morning all. Yeah, I'm Laura Tyler, Assistant Director for Joint Commissioning, so relatively new to the role. Penny is going to take you through a presentation this morning just to update the committee on what we're doing in relation to our submission for the Better Care Fund, and then I will just explain regarding the metrics and where we've got to with that. So I'm going to hand over to Penny in the first instance.
Morning, thank you Laura and thank you Chair. I'm Penny Basin, Head of Joint Partnerships for Shropshire, Tilbury Region CCG and Shropshire Council. So we have collaboratively put together the Shropshire this year. It is quite late in the year, you'll note we received the guidance in October, I think the around the template and the guidance to deliver, so we're sort of in an in-year position where the Better Care Fund was already working as it has done over the last number of years. So this is summarising what we're doing locally for this year. There were some interesting additions as well to the guidance that came through, particularly around the metrics. So us alongside other areas are working collaboratively to figure out how we talk about those, how we report back on those metrics, because it's different to what we've done before, and then also looking for the years ahead, that expectation that there's much more focus on the Better Care Fund, particularly around hospital discharge, which we'll know from the news today is really important for our collaborative working. So I'm going to whiz through the slide deck because all of this really is in the papers that you will have received, but happy to take any questions. Our Better Care Fund is about integrating our services and providing an enabler really for pooling budgets and being able to work collaboratively and make joint decisions on how we use our money to better effect for people, essentially. Are the three themes that we focus on and have done for years around the Better Care Fund are prevention, so we want to stop people from being ill in the first place, and we want to avoid people going into acute care in particular, and then once people are receiving treatment, that they're able to move out of acute services if it's possible. So the key changes, as I described in the policy and guidance, were around the metrics, also the impact change, high impact change model has kind of been removed from the narrative, although we still work with that locally. So in the past we reported around the high impact changes guidance, and we're still working to those, but they're removed from the guidance. New metrics, and then asking for a narrative plan to be aligned around our governance approaches, our overall approach to integration, our supporting discharge, disabled facilities grant, and how we contribute to health inequalities. So all of those sections are included in the paper that you've received. And there are the national conditions that again are as they have been for some time, so I won't go through those. Locally, our governance is updated as it needs to be, so this is a kind of look at where we're at now. We obviously have the Health and Wellbeing Board, we have a Joint Commissioning Board, we've had a newly formed Joint Commissioning Delivery Group, and also some new posts. So the Assistant Director, as we met this morning, is new around Joint Commissioning. My post is a relatively new post and really focusing on our joint work across the system. Our approaches to integration. So we've been working through the Shropshire Integrated Place Partnership to focus on keeping people well in the first place. So this diagram kind of demonstrates that, our real principles of working. So focusing on inequality, focusing on integration and collaboration, focusing on taking a strengths-based approach, so that person-centered. So how can we make the best of people or individuals and their abilities, and then communities and their abilities, and also our workforce and their abilities, and also taking an evidence-based approach in line with our SHIP and Health and Wellbeing Board priorities. Again, this just highlights our key themes, so prevention and inequality, admission avoidance, delayed transfer, system flow, and then listed within there are our key programmes. So around prevention, we've got healthy lives, we are developing healthy weight strategies, and they all kind of impact here: social prescribing, population health management, carers, mental health and early help, children with service and young people. Around admission avoidance, our local care programme is focusing on rapid response. So what Nikki O'Connor was referring to earlier, getting to people where they live in a rapid way to keep them well in their own home. Case management and respiratory. We have an integrated approach to our occupational therapy, our winter pressure schemes, again focusing on carers and community services. And for our discharge, or for our system flow, we have in the advent or sort of following COVID, some really positive joint working through our Hospital Discharge Alliance, which again uses that 9 high impact model, discharge to assess, and our start reablement team is a focus within there as well around how we can move people out of hospital as quickly as possible, assistive technology and Pathway Zero. So our Discharge Alliance, as I said, is formed, following the kind of really successful way in which we were able to move people very quickly out of hospital when we needed to with COVID, and then those principles of working were developed into Discharge Alliance, and these kind of the purpose to improve our performance in Shrewsbury, Telford and Wrekin. I won't read through those, but they'll be there for people, and they're within the papers as well. Our disabled facility grant again really focuses on working collaboratively, but also using a multi-agency, multi-funding, multi-option approach for people. And that example that we listed there, House to Home, which again is in the papers, is an example of that. So there's a disabled facility grant, but around that we've got other grants as well, so we're able to make the best use of what we've got. From a governance point of view, it's agreed through our joint commissioning board, and we'll be working through the delivery group as well. If I just hand over to Laura now for the metrics, it might be a bit small, this slide, but again, this is included in one of the tabs in the Excel spreadsheet, which is the template, but just handing back over to Laura to discuss in a bit more detail.
Yeah, morning. Well, thanks for that, Penny. I think it's probably easier, just to have a look at the actual paper that we submitted. So, as Penny said, we've got additional metrics this year. I don't think anybody was expecting it, and I think it's fair to say that every local authority has been battling in terms of setting those metrics and what that should look like. But particularly the focus for us is looking at length of stay for 14 days and length of stay 21 days. Those are the ones that have been particularly difficult to set, I think. What we have is some data packs that have been sent nationally based on a local authority area. So they have, and you'll see in the table that provided in the Health and Wellbeing report, that it's based on an average 18 months data pack set. The concern with doing that is that 18-month also includes the COVID period, where we know that it has, I suppose, skewed our data somewhat across the system. So what we've done is we've looked at the average data set for over the 18 months, but we've also then looked at what that average is as well against quarters 3 and quarter 4, because we know as a system that quarter 3 and quarter 4 are always quite a difficult time of year. So we've set the targets based upon really those quarter 3 and quarter 4. So you'll see that it looks like we're not putting any stretch targets in. However, as a system, we feel that they will be very much stretch targets. We know, over the last few months in particular, that the pressures on the acute and the issues that we've got across workforce and recruitment. So those targets have been very much set against a background of increasing pressure. And as I said, we feel that they are going to be quite stretch targets. What we'll do is we will work with we will set this within the Alliance group, the Discharge Alliance group, to monitor these. But I think it's fair to say again, all local authorities are struggling in terms of understanding and knowing what we're going to put. when we went to some of the regional meetings, they've been very much, you know, as long as we've got a really just, you know, an understanding and a justification as a system why we are setting those, and we are really clear about how we are trying to meet those challenges and what we are doing in the future, they're happy with what we're proposing so far. So as I said, we've got length of stay 14 days, length of stay 21 days. We've got a new one around percentage of people who will go home, so we discharge back to their normal place of residence. Again, that's an average annual target. We've kept it the same. We've kept it the same because we know we've got real pressures in getting people home, particularly with the recruitment retention, with the in the domiciliary care market in particular. So we have seen an increase in number of people potentially going into the care home. So we've looked to maintain that, but understanding that that will be a stretch target. And the same for unplanned hospitalisation for chronic care sensitive conditions. We've done the same. So the target there is based upon what the trajectory would be for the annual target. So we've set that as it would, as CCG have worked with us, and that is what we believe would be the trajectory target for that. But again, I think that is very much a stretch target when obviously last year, etc., we didn't have things like flu. You know, people were in isolation, so we don't know what that figure is going to look like in the next winter period. So that's why we've set those metrics like that. We've had some, as said, Penny and myself have sent it through the region to sense check it and to get some initial feedback on our submission. So we're working on that, and we will obviously be working with the system to make sure that, you know, they are happy prior with submission prior to, I think it's the 16th, isn't it, Penny, the submission now?
Yes.
Yeah.
That's right, yeah.
I hope that explains very briefly the overview in terms of how we've set the metrics across that. But, you know, it's very much kind of business as usual. I will say, as we are also going to review all of the BCF strands and plans moving forward, so to make sure that it is fit for purpose as well, and that we are doing everything we possibly can to you know, to improve and to work as a system. So that's a piece of work that we will take on probably towards the end of this year, early next year. Any questions?
Yeah, Penny.
Can I just come back in just to kind of sum up where we're at with that response from the region? So we did provide our narrative document and the template with finances to the region for early comment, informal comment, and we have had some comments back, which was some really positive comments about it, but a couple of areas where they suggested that we further link the narrative document with the expenditure tabs, particularly around enablers, so particularly thinking about domiciliary care and how we're going to keep people or move people through the system more quickly. So I think that was one area that we needed to bolster within the narrative document, matching back to the template, the financial template. And the other area around the metrics, although we explain why we are setting the metrics where they are, there was a request to have additional ideas about kind of where we're at now, what our challenges are, and how we're going to improve those, you know, make those improvements. So a little bit more comment there. So that's why within the recommendations of we knew this kind of was coming, so we submitted this report to the Health and Wellbeing Board, knowing that we were waiting for regional comment. So we've asked them within the recommendations if the board would agree to have sign off by Tanya Miles outside of the board meeting. I think I said specifically, I don't have the report right now. But yeah, specifically, just so that we can make those adjustments. The region haven't suggested that we need to make any adjustments to the finances. Overall, it was positive. There's just some tweaking of the narrative document that needs to be made. So we're asking for kind of devolved decision making on that within the next week, because it is due on the 16th of November.
Thank you. Do we have any questions at all? Tanya.
So thank you, Penny and Laura. It's great to see both joint funding post holders doing a joint presentation on BCF, all about integration. So great to see you both today. Just in terms of hospital discharges, so we know that this system performs really well in terms of discharging patients in a timely manner from home. Laura, it'd be great to hear a bit of a rundown in terms of the additional capacity that the Shropshire system has put in place to support this system as we go into winter. And Health and Wellbeing Board will receive a paper on the Shropshire Winter Plan in January board. But it would be helpful, I think, Laura, for members just to hear some of those high-level details in terms of the additional investment that the system has received just recently, this last week, from our CCG colleagues. Thank you.
Yeah, absolutely. So yeah, we've been working, as Tanya said, as a system to look at what we could do with some additional capacity and where the biggest impact would be. So together with Telford, colleagues have worked on a proposal and have successfully managed to get some additional funding to really bolster, first and foremost, our enablement team to ensure that we've got through start to pull people out of the hospital really quickly, and also to have an element that will support for the domiciliary care, because we know that throughput there has been a bit of a few issues with the throughput to get them out into the market. Thankfully that is starting to improve. So we are seeing, as I think Tanya described it, some green shoots coming through the system. So that's what we're doing there. I think it's also if I may, just some of the more wider elements that we're doing to try and support systems. So whilst we've got that additional investment, we're also putting a recruitment and retention campaign that you will see kicking off hopefully today, tomorrow, really to try and support the health and social care recruitment and retention scheme, and really promote the brilliant work that people do, and trying to get people to come into the sector and keep them in the sector. So that's going to be an ongoing campaign. It's quite timely because actually it links with the national campaign that's also going on. So that's an additional piece of work as well. And we're also looking at how we can commission differently, looking at how we can model things differently, looking at contracts, terms, conditions, etc. So there's a huge amount of work doing behind the scenes to try and support the system, and we will continue to do that to make that difference and make sure that people do get home in a timely way and are supported.
Right, thank you for that, Laura. Yes, Penny.
I think included within that is, I'd just like to mention the prevention element. So there's some additional winter pressure funding going into working with our voluntary and community sector to support people in their own homes, the whole wide variety of support mechanisms. And I think that's going to be really important as well, because we want to keep people as well as they can possibly be in the first place. And the range of support that is out there and things that people can do and support themselves, from vaccinations to warm homes to food, to all of those things that will keep particularly our elderly population well this winter. So there's a lot of emphasis going in at that prevention end as well to support people.
Thank you. Any further questions at all? No, right. Well, we've been asked to note the contents of the report, the recommendations. The Health and Wellbeing Board notes and approves Shropshire's PCF planning template submission in both Appendix A and B, and the board approves delegated authority for final sign-off of the plan if regional feedback suggests amendments following the Health and Wellbeing Board. Are we happy if I move those recommendations? Everybody in favour? Yeah, that's great. Thank you. Right, next item on the agenda is item 7, health inequalities and wider determinations of health. Before we go into that, I did omit to say at the very beginning that I will be actually stopping the procedures at 11 o'clock, so we can have a stand for the 2-minute silence. Okay, so hopefully if that'll be a natural break for us. Right, so Health and Equalities Plan update, Bernie Lee, Consultant in Public Health and Shropshire Council. Bernie.
Sorry, just getting myself off mute.
That's all right. It's the perennial problem at the moment, isn't it? You are on mute. Okay.
Am I sharing my slides?
You are, yes.
Excellent.
If you could go on to slideshow though, because it'll give us a larger image.
Okay. Can you see that now?
No, we're not on slideshow yet.
Oh, hang on. It is for me, so I'm really sorry about this. Hold on.
It's obviously a delay then, yeah.
Oh, okay. Let me, I've got them full screen here, slideshow.
Well, hopefully we will drop into slideshow as well in a few seconds.
Oh, I'm really sorry about that. Shall I begin?
You just, start the presentation then, thank you.
Okay, thank you. So, well, good morning, everybody. And so for a health inequalities paper, but you will have already heard quite a few references to health inequalities, both from Nikki and Penny this morning. Well, I've pulled these slides together to pull out the key points included in the paper, but I guess I won't pick everything up. So if I do miss anything, please, hope you have opportunity to ask at the end. So Shropshire's Health Inequality Plan is intended to draw together in a single document a range of plans and priority work programmes that are already underway on our footprint. So the provisional intention is that we document, if you like, at a high level, a summary information in relation to those existing plans and pull those into this Shropshire Health Inequalities Plan. However, I suppose in looking at relevant data and information, we may identify gaps in their activity, in which case there may be a need to sort of start additional or enhance work programmes. The plan will include priorities for tackling health inequalities that are relevant to the integrated care system, that are health and wellbeing board priorities, or those relating to the wider council. So the board will have seen this population health model that's shown on this. Each of the work programmes to be included in our plan will be aligned under one of those 4 domains. And I had a meeting yesterday with the Shropshire Council and CCG colleagues, and we acknowledged that the range of relevant work programmes that are underway are many and varied. And whilst we might want to include some reference to these in the plan, we will also need to be a bit more selective in terms of the priorities against which we will measure our progress. So we basically don't want to sort of create an industry whereby we spend more time documenting activities and progress rather than actually delivering these important work programmes. So I think what I'd say is we'd endeavour to get the balance right. On to my next slide. In terms of the key programmes that we do identify for more detailed performance management in terms of delivery, we will be mindful of the evidence, sort of both in terms of the factors that predispose individuals and population groups to health inequalities, so those listed in the grey box on the left side of the screen there, as well as
we're still on the first slide here.
Yeah, I was hoping you weren't going to say that. Let me just go back to my screening. If I stop sharing and start again, it might be better. So I've stopped and I will start again. Can you see that now?
That's the 3rd slide.
Okay. So I will now go back to the 2nd slide.
That's better. Thank
Lovely.
you.
So sorry for this. So as I say, the left-hand side there, the grey area on that screen, it sort of documents the key factors that predispose individuals and different population groups to health inequalities. And then on the right side is the evidence provided through the national Marmot reviews, whereby the key areas where the evidence indicates we should focus our attention in order to reduce health inequalities. So you're starting at the top there, areas of action. Under there, the top line, sustainable communities and places. So we need to, and this has been referenced in what has been shared with the board in the other sort of items this morning. Then below this, but I think of equal importance, I would say, we need to be promoting a healthy standard of living. And in that, of course, we need to acknowledge the importance of central government's role in that as well. Then the green boxes that sit below on the next row, the importance of the early years, of skills development and having a decent job, and how the impacts of these factors sort of accumulate across the life course. So, you know, if you have poor experiences in the first 2 years of life, then these can be compounded by poor educational attainment, followed by low skills, poor job prospects. And I suppose, you know, the critical importance of prevention and early intervention to ameliorate these kind of negative influences is sort of illustrated there as well. And Sir Michael Marmot makes the case for universal services that are delivered sort of proportionately to the level of need. So basically, we all need something, but some need more than others. So moving to the various priorities that will be, the various priorities that will be included. I'll first look at the integrated care system priorities. So the Population Health Board is a group sitting under the Integrated System Board, and it's chaired by Andy Begley and Rachel Robinson, and that is overseeing the development of the system-wide approach to health inequalities, which includes NHS England's health inequality priorities for integrated care systems, and they are listed on the left-hand side of the slide there. And then the diagram on the right illustrates that there is like an overarching framework for the system-wide prevention and inequalities programmes, and that alongside this sits the priorities local to Shropshire. Onwards, a little bit more detail here, more granular detail around the NHS prevention programmes and the transformation programmes that will be delivered to Shropshire residents, and that could have should have a significant impact on our population if they access the services as intended. And then alongside those NHS priorities, our local priorities will sit. Although you will, of course, recognise that in these local priorities, a number of those are sort of shared with the NHS. Now, I think this list here isn't intended to be definitive or comprehensive at this point, not of all of our local priorities, but it does illustrate the range of complex sort of issues that need to be addressed. And I'm really pleased to see on this agenda today that you've got more detailed reports relating to food insecurity and fuel poverty. And I think that these will help to illustrate the complex web of issues, if you like, that sit behind these problems that blight the lives of those affected. And then in looking at the principles that will underpin our approach to health inequalities, the first is the need to adopt a whole system approach to the issue, sort of recognising the complexity that sits behind problems and the vital importance of understanding problems from the perspective of those with lived experience. And I'm pleased to say, actually, we've been successful in a bid to the Local Government Association in securing monies £300,000 over 3 years that will include an opportunity for a local learning programme in relation to adopting whole system approaches, but I'm sure there'll be more about that in future meetings. But other important principles are listed here on the right side of the slide there. But in addition, in our meeting yesterday, the need for co-production to be added to those principles. So co-production in how we tackle these problems also needs to be included. So in terms of my final slide, the top boxes show how we have mapped the Marmot evidence-based objectives against the population health domains, and then the second box sort of illustrates the summary detail that we intend to include in our plan for each of the priorities that we want to focus on. So for each, we will be saying, why is this important in the context of health inequalities? Who is the lead organisation responsible officer for the relevant work programme? What are the key milestones? You know, what are the metrics associated with it? And I will be working through the Shropshire Health Inequalities Group and the SHIP in agreeing the content and the detail, and I'll obviously report back here and to the Integrated System Population Health Board prior to sign off, and that should be by April 2022. And I think just to one point, because that was raised early in the meeting today, Councillor Motley making the point around the issue of access to services in rural areas. And in section 3.8 of my report, I make reference to the opportunity that we can expect to have around, you know, introducing a specific focus on rurality as a challenge, as a, you know, a factor that we really need to explore in tackling health inequalities. So I just thought I'd add that in. And then I think that's all I was prepared to going to say, but I think, Rachel, I would like to suggest you might think I've missed something important before I ask you for any questions.
Thanks, Bernie. I think you've covered off a lot of what I was going to say, actually, particularly in terms of the final point you made around rurality and the importance of place, and really particularly in Shropshire, but in any area, of understanding our people have termed it neighbourhoods, communities, and having that more targeted approach, which is where the pandemic has shown us that actually one universal approach, we know this doesn't work always, and actually what you need to do is understand your populations and have that really targeted local approach, and that is, and understand the complexities within populations and communities, and work collaboratively to address those. And I think it's, you know, for me, the fact that we've got inequalities within so many of our papers, I think the breadth of the agenda today, as you've said, Bernie, and the work that's going on shows how all of these are joining up, and the work that's already underway. And this is really an approach to trying to bring this together in our framework, make sure that we are continually reviewing and understanding what our priorities and inequalities are. And then also there's a significant amount of work already undertaken within these areas. I think what's exciting is that we are aligning all of this work both across Shropshire and Telford and Wrekin. There is that joint framework that we're developing to make sure it's embedded into all of our programmes and policies, either as a council in terms of our health and all approach, but as an integrated care system in terms of that framework. And then pulling together and making sure that we're joining up on those NHS England priorities, so that we see that thread running through, and that these aren't standing in isolation. And I think you've set really well for us the context of why we're doing this, that population health approach, and the complexities and the issues that we're dealing with. And I know we've got more items on the paper, so not really much to add, just to say, you know, I really welcome this being brought here. I really welcome that we will be producing the plan, so that everybody will be clear and transparent, the work that is going on across this area. But I hope that people can see the complexities of the work that we are working to address. So I'll leave that there. Sorry, I just realised my camera wasn't on.
Thank you very much, Bernie and Rachel. Do we have any questions at all? Yes, Cecilia.
Thanks very much, Chair. It's really just a comment, Bernie, just to welcome the specific focus on, you know, trying to determine the problems occasioned by rurality. And it just a suggestion for you. that when you get to that point where you want to go out to, as it were, wider consultation, that it would be probably very helpful for you to contact rural parish councils, who all have a very good knowledge of their local communities and the problems within their local communities, and the health determinants also within their local communities, and they could actually just add granularity to your approach.
Yeah, I mean, that's, you know, a great suggestion, and I think it's really where Rachel was coming from in terms of saying, you know, we recognise the need to really work in partnership with all agencies and, you know, our communities. So yes, I think, and I'm really hopeful. I think Rachel and I have got a meeting later this morning to actually explore this in a bit more detail with our NHS partners. So we think good opportunity here.
Okay, Jackie. Yeah.
Hi Bernie, hi Rachel. I just wanted, it's not a question really, it's just a thank you as far as kind of myself and the voluntary sector, they're always banging on about with the joint strategic needs assessment about moving up, adding on to the wide metrics, the wide statistics, the wide things to actually that granular level and coming down, and with public health, and I know we've had the pandemic, so you've been grounded in the county, haven't you, for the last 18 months, but that really shows in your approach and in this and in addressing health inequalities. It's not just about the bigger picture, the bigger trends, it's about what happens in communities, and it's just a thank you that we've seen that approach and that change.
Thank you, Jackie.
Okay, thank you. And we've I see there's a hand up. Is it Vivek? Vivek, yes.
Thank you, Councillor Jones. It's just to make an offer really on behalf of the ambulance service here for Bernie and colleagues around public health and health inequalities. You know, we hold quite a bit of information and data. You know, we obviously cover the whole patch and the rest of the region. So if there's anything we can do to help in the work that's happening locally within the county, then, you know, we'd be very much happy to oblige and do what we can to help you, Bernie, and the team around, you know, some really great work by the sound of things on reducing health inequalities and improving upon public health.
Thanks ever so much. And you know, I will say that the work that we do is greatly enriched by the support we get from, you know, third sector or other organisations such as yourself. You know, we really are benefiting from that kind of collaboration.
Okay. Right, Dr. Pepper.
Yeah, many thanks, Bernie. John Pepper, CSOG Chair. Bernie, a lot of very good stuff in this plan, and particularly, you know, I picked out the introduction of alcohol teams, the focus on improving children's mental health. I guess the comment or the observation I had was really where education really sits in here in terms of wider determinants of health, and I know that it is referenced, you know, with Appendix 3 regarding the looked after children's importance regarding academic achievement and reducing school exclusions, and also in Appendix 4 for, you know, employment and training, particularly for those with learning disability. Really a comment really as to whether education sits outside the remit of the Population Health Board for this, but it was just a comment that I think you know, it'd be good to have that real focus of education being one of those wider determinants as well within the plan.
Can I just say that came up in 2 meetings I was in yesterday, actually, and it is really, really important, and I think it absolutely has to be in our plan, because, you know, as I made reference to Sir Michael Marmot's work, it is what happens in those early formative years that really set the pattern for future life. So we won't be able to address health inequalities unless we get young people off to the best start, and, you know, looking at educational attainment and what's in place to support, what are the barriers, what are the opportunities, you know. And yes, it came up, as I say, in 2 of my meetings yesterday, and individuals saying I will go and look at what the relevant measures and work programmes are. So you know, I am expecting that to feature in our plan.
Great, thanks, Bernie.
Thank you. There's no further comments at all. We're asked to note the contents of the report and suggest any specific areas of concern not specified in the report and should be addressed through the plan, and identify any further information required in relation to health inequalities and plans to address them. Oh, and I haven't had the microphone on, so I hope you all guessed what I was saying there. So are we happy to note the contents of the report with those additions that we've made? Yeah, that's great. Thank you very much.
Thank you.
Thank you very much, Bernie. Next item on the agenda, we're sort of almost on time actually. Food insecurity findings report. A presentation from Sophie Paget, Shropshire Food Poverty Alliance, and there are 6 recommendations on this. Sophie.
Hi, thanks everybody. So I'm Sophie Paget and I coordinate the Shropshire Food Poverty Alliance. And as Bernie was saying, it's a really good presentation to follow up from what she's just been talking about, looking at the start that children get in life and food being a really integral part of that. Could you pop on to the next slide, please, Val?
I've done it, Sophie.
Oh, it's not moved on my screen.
It has on ours, so if I say it's moved on, is that okay?
Yeah, that's fine. I've got one here. Lovely. So we did a piece of research over the winter of last year and into the early spring of this year, where we surveyed 41 schools and 56 other organisations in Shropshire. We also held 3 online discussions, which had a really broad range of people from across all sorts of different sectors. We put together case studies of local initiatives across the county that are already supporting children with food, and from that we learned some really interesting things. So probably the most concerning thing that came out of the report was the level of concern that people were reporting around children's food insecurity. So of the schools we surveyed, 77% were concerned that there were children within those schools that might be going hungry because there wasn't enough food in the house. Like we've discussed already a lot here, Rurality was consistently commented on as presenting additional barriers. And for us, those barriers came up in 5 main themes. So that was lack of rural transport, infrastructure, lack of affordable food retailers, the rural fuel premium that many households face, limited or no internet access, and the low wage economy that exists in Shropshire. So then we had a look at the government funded schemes that are already in place to support children with food. And I'll come back to these a bit later, but it was interesting to note that the Healthy Start vouchers, which are a really vital nutritional safety net for low-income families with 1 child, only half of the people in Shropshire eligible for those are actually signed up and receiving them. And when we looked at free school meals, there was concern that not all families who were eligible were signed up, but also that there were families that really could benefit from this sort of support but didn't qualify because the threshold is still really very low. And time again, the barrier that was cited for coming forward for this sort of support was stigma. We heard it again and again that we've got a quote here that says people don't apply, they worry that somebody will find out, they still think that there is a stigma attached. Could I have the next slide, please, Val?
Okay.
Lovely. So then breakfast clubs, we had some really wonderful feedback from schools that had run or were running breakfast clubs on the range of benefits that they offer. So it was clear that provisions like this is about more than just feeding children, it's about all the additional benefits that come along with that. So the quote we've got here talks about giving parents the option to work, children options to interact with their peers, children even completing homework at breakfast clubs, helping with punctuality and attendance. So they're really a really positive thing when they can be implemented. 60% of the schools that we spoke to ran breakfast clubs. Fewer than 5% of those were reaching more than 30 children, primarily because we have so many rural schools. But the real concern there was that the breakfast clubs weren't actually reaching the children that they were most concerned about due to fixed transport times in and out of schools. Holiday hunger again came out as a concern, but interestingly, we had 65% of people telling us they would like to see a move away from food parcel provision and that vouchers are a much better way to support families and children with food during the holidays. And then we heard from schools in all the inventive and creative ways that they are supporting children. So we've got some of these in the case studies that are up on our website, but all sorts of interesting building children's food skills and helping to build healthy attitudes towards food. Could we pop on to the next one, please, Val?
Done.
Lovely.
Done.
So then these are the recommendations that were in the paper that I submitted. I pulled out 2 that I think are particularly timely at the moment, but I'll talk you through all 6 of them. So the first one was around rurality and looking at the additional barriers that presents and how we might overcome some of those. In our recommendations, we've split them up into things we think could be done locally and things that we recognise are really down to central government decisions, but have included the barriers that exist at that level, just to give context. The government funded schemes designed to support children with access to food. So here we're talking about free school meals and Healthy Start, those not reaching all families that need them. In particular, I think Healthy Start is something that is a really timely thing to start to think about working on and getting a higher level of people who are eligible signed up for that. Currently, the scheme is a voucher system, but they are in the process of digitalising it. And from the end of March next year, everybody will be on a prepaid card system. So that seems like a really important time to be pushing out with comms. And what I would love to see is sort of a cross-sector Healthy Start task force that looks at what the voluntary sector can do, what the council can do, and what the NHS can do to get as many people signed up to that as possible. The third piece was around breakfast clubs. So that's talking about how we can support schools to consistently run these breakfast clubs. A lot of schools told us that they had at some point had a breakfast club, but staffing and budgeting restrictions has meant that they just hadn't been able to continue to run it. Could I have the next slide, please, Val?
Okay, done.
Thank you. And then the fourth point is around this, the wider roles that schools play around food and the power that they have to shape attitudes around food and also build food skills. We've got some really excellent examples in Shropshire schools that are really going above and beyond and doing all sorts of inventive things, but they've told us that it's a risk that they take and that it isn't facilitated within the national curriculum and also within the budgeting and the immense strain that schools have been under this year anyway. The fifth point is around holiday hunger and that point around a shift away from food parcels and towards vouchers, and importantly a consistent provision of holiday provision, because we know that the holidays are some of the most difficult times for low-income families. And then the sixth point is around the reach and impact of community projects. So it was really lovely as we were putting together the case study to see all the things that already are happening in Shropshire. There's interesting partnership projects, there's things going on in schools, things going on within the community. And there's been a real, as there's been so much coverage about things like holiday hunger, thanks to people like Marcus Rashford, we have seen a real surge of enthusiasm. So it's looking at how we can harness that enthusiasm, but also, the reality that a lot of these projects are run on a lot of goodwill and people are quite burnt out. So I think looking at all of these strands of work, the Healthy Start is probably the most timely thing we could act on, but I also just wanted to stop and talk briefly about putting dignity at the heart of any of the strands of work that we do. Stigma across the board, from our research, from other research, the project that Bernie was talking about that's just been funded for 3 years had similar feedback about the role that stigma plays in preventing people from coming forward for the support that they need. Really needs to be central in anything that we're doing. So when we're talking about reducing stigma, we're talking about respectful communication, training of frontline staff to understand the impact that living in food insecurity and the complex web of issues that often includes, centering people with lived experience and their voices, and also choosing the most dignified methods of support possible. So trying to shift away from this food bank, food parcel model and really promoting cash first and voucher options where they are available. And if you could just pop onto the last slide, Val, that would be great. Lovely. And so here, this is just a little bit of evidence from other sources that backs up what we've found and also explains why we're quite so concerned about this as an issue going into the winter. So we know that the number of children eligible for free school meals in Shropshire has risen by 48% since pre-pandemic. The universal credit cut that came into force in October is of big concern to us. Modelling from the Joseph Rowntree Foundation shows that this can push about 500,000 people into poverty, 200,000 of which are children. And in Shropshire, I think it's actually about 19,000 people that are currently in receipt of universal credit. So, you know, this is people in Shropshire, and it's worth noting that this is an in-work benefit. 48% of people in Shropshire, 43% of people on universal credit in Shropshire are actually in work. And then the Food Foundation's report really just shows similar things to what we found at a local level, that food insecurity existed prior to the pandemic. The pandemic has exacerbated that, and unfortunately the economic landscape that we're facing at the moment doesn't look like it's going to get any better anytime soon. So that's a bit of a whistle-stop tour through everything. So thanks for listening. It's been lovely to be able to bring it here.
Thank you very much, Sophie. Now, I don't know, are there any questions at all for Sophie? Yes.
Thank you, Sophie. I think you've answered my question. I'm Councillor Hurst, I'm portfolio holder for children and education. I did note on the first slide, I was just going to ask you about the Healthy Start and the lack of families signing up and the eligibility. Really, if I get in touch with you after this meeting, a further conversation to be had around that, especially as I'm out about visiting schools again. So I'll drop you an email and we can have a further conversation. Thank you.
Wonderful, thank you.
Penny?
Thanks. I just wanted to take the opportunity to update, I suppose, what's been happening with the funding that Shropshire has received on the back of Marcus Rashford's campaign around holiday hunger in particular. So through the end of the end of the beginning of the pandemic, we started to receive funding for holiday hunger about March time last year, and or a bit before that. So that funding has been used for free school meal vouchers in particular, but we've also worked with our voluntary sector organisations to be able to provide funding, because what we recognise is that there's it was between about 7,500 children receive free school meal vouchers, and we expanded it to those who receive it also to those who maybe were on the fringe. So schools had a bit of leeway to give vouchers to people they recognised needed it, even if they didn't actually apply for them, or even if they didn't make the threshold for the free school meal vouchers. So there was a bit more, there were a few more children receiving them than maybe would have been getting free school meals, is what I'm trying to say. But then we also worked with partners to make sure that people who maybe came through different routes, highlighting their need, that they would be able to access funding the other way. So there were, fuel poverty grants and things like that. So through around fuel, around facility, the utilities and that kind of thing, people were able to get a bit of support through that. The funding has come down in different tranches. So we're now on, I think, our third, and they call it something different every time. So currently it's called the Household Support Grant. And so we're working collaboratively as well with our voluntary sector to see how we should be spending that in this area. And we're focusing on doing it in a number of different ways. One, through the school vouchers, because we know that does provide direct support for children who are in hunger, but also through benefits, also through the welfare team within the council, but also through the voluntary sector, through the utilities, being able to provide grants and whatnot through utilities. So there's a range of ways in which we are trying to impact and make sure that people are supported. I don't think it delivers everything. There's still a lot of need out there, but that's, we are looking at this and trying to take a kind of multi-agency approach and working with the Food Poverty Alliance really closely to be able to do that.
Yeah, and can I just say, we were really, when we've been sat in meetings on how that household support fund is going to be used, we really welcome that so much of it is going out, as direct cash to families. It was really wonderful to see.
Yeah, Jackie, you first.
Yeah, me again. I'll start with a thank you. Again, that actually we feedback and say a lot about how there has to be a shift in attitude, and it's great to see that happening, Penny, and being part of the discussions around the household support grant and cash first. Sophie talks about stigma and how we need to address that, and when I talk to other voluntary sector agencies who try and support people to access support, there's a lack of empathy about how that person has got to that place, and a lack of empathy in setting policy, procedure, and how people access that. There's always a an attitude that people are there to book the system to get money that they don't really need. And actually that's a very small percentage, and actually the majority of people who want help and need help are there through no circumstances of their own. And we talk about the perfect storm. Sophie's mentioned universal credit, we've got fuel poverty, we have food poverty, we have poverty across the board. And so that introduction of empathy and understanding how people get to that point will help in making sure that people can access services in a dignified way. And I think it's great that we've got that started already, and there seems to be a shift. But I would ask is that the Health and Wellbeing Board review this again to make sure that there's a continual shift towards dignity and to challenge and eradicate the stigma around poverty in Shropshire.
Thank you, Jackie. Mark.
Thank you. Sophie, thank you for this work. It's interesting and sad at the same time. I'm sat here with an emotion of horror, really, to be honest. Just a couple of reflections. I get the phrase food insecurity. It's the way we professionalise this. I don't like it. This is hungry kids. And I think we should call a spade a shovel on some of this stuff. My question is this one, which is, and it builds on the last point, very concerned, of course, about the children and the families that are eligible and not accessing. And we just heard some of the reasons why people might not access. What's our expectation of the campaign that's mentioned in the paper? So how ambitious are we about supporting people to take this up? So first part. Second part is, what can the local NHS do to support that? Equally, are the things that the local NHS shouldn't do, which will stigmatise and get in the way? Thank you.
Thanks, Mark. Yeah, it's a really good question. In terms of the scale of the ambition, I think, you know, the fact that these already exist and that they're here, we should be ambitious in that everybody that is entitled to them should be claiming them. That's the ideal, that we get everybody signed up. In terms of how we can go about that, I think there's stigma. There's also confusion around the transition. If a child's been on, because we've got universal infant free school meals, and then when the child gets a bit older, you have to reapply. I think it's having the information available. We've got things like new resources such as the Cash First referral leaflet for Shropshire, and I think it's knowing how to approach these conversations sensitively. So we're also running training sessions along with citizens' advice for frontline staff and volunteers who do that sort of light touch signposting. So, you know, they're not necessarily going to go into really the sort of detailed advice that citizens' advice can give, but they know how to approach those conversations sensitively. So I would encourage people to sign up to those sessions that we're running. In terms of what not to do, I think anything that is involving any form of sort of judgment, or, you know, effectively we're not there to judge whether or not people should be signed up to things. We've had feedback about sometimes GPs not wanting to necessarily refer through to food banks to make people dependent and this sort of thing. You know, maybe an understanding that people are eligible and they deserve the information, and that, you know, it's not for us to decide who is and isn't deserving of certain support, just making that information openly available to anybody who may benefit from it.
Right. Thank you for that. As there's no further sort of questions, I'd just like to say that you know, I'll ask the board to note and receive the report, and ask the board members make comments and email Val, who will collate and share with the shaping places. Okay, so if all members can do that, thank you. So we note that report. Moving on to the next item, which is Energy Redress Project. Simon Ross, Director of March's Energy Agency, MAE. Now, I might have to interrupt your presentation if we hit the 11 o'clock for the silence, okay? So don't be surprised if I interrupt you. All right, thank you.
No, that's fine, thank you. I think I'm screen sharing from my end, aren't I, Val?
Yes, please, Simon.
Is that coming through okay for everybody?
Yeah.
Great. Okay. Well, thank you for the opportunity to present this morning briefly. I just want to provide a quick update on Healthy Homes Shropshire project, which I brought forward just as we were getting the funding back in March. The aim of the programme, which is around helping vulnerable residents stay warm and well in Shropshire. So it's just a brief update on where work has got to. It's in the context of a lot of wider support that we do around energy and struggling householders. And we've just entered our 25th year of service, so that's quite impressive, I think. Quick summary of the work to date. It's 2 years of funding, so we started in March. We're about 9 months in now, so we're just warming up, no pun intended. But we've got a decent project manager in place, and we're just starting to gain some traction around all of it. It's been able to provide us with funding for 130 distinct casework support sessions for local residents. We've done some training. We're working with Jackie and Heather from Age UK, so we've got some additional benefits checks flowing, and through Age UK we're just starting to plan in Bridge North Library, Pontypridd Market, Drayton, Whitchurch and other locations. And we're also looking to link into a range of other funded programmes, mainly capital programmes, which we're working closely with private sector housing on at Shropshire Council as well. So there's lots going on. We've started to gather a little bit of feedback, and here's a little bit of what people are saying about the service that we've been providing. They are able to heat their homes to a comfortable temperature, and they would recommend our support to family and friends. Just briefly, interesting, we did try to use MyCall, which we're aware is a sort of an NHS public health standard, but frankly we weren't able to get on with it, so we've adapted it for our own needs a little bit. Healthy Homes Shropshire, so a cold home is a key consideration around all of this. These figures are provided from Public Health England and adapted for their cold weather plan in 2017, but the numbers won't have changed. And by the time you get below 18 degrees, 16, 14 lower, then you're starting to open the risk of health issues in homes, high blood pressure, cardiovascular, diminished resistance to respiratory conditions, hypothermia, and potentially even death as well. So there are considerations in relation to this from a health perspective. Just thinking about the health conditions that we have been supporting in Shropshire. So this is since April. We've supported 560 householders since April. Of those, 228 are telling us they've got a health condition of some description. So that's just over 40%. The big health conditions that we're supporting people with: cancer, cardiovascular, reduced mobility, musculoskeletal, respiratory and mental health as well. So there are a lot of people with health considerations that we are seeking to support as best we can. We're aware of the integrated care systems work, and I think this is probably my key message for now, is just, frankly, we need help. We need help from people inside the NHS public health system just to help us understand what's going on. I see things like the integrated care system proposal. I can see the need for strong-based partnerships. I can see the need for wider determinants of health, and interesting to hear those conversations earlier on about sort of young people and the crucial conditions they experience at home and wider to get going in life. A role for the voluntary sector, starting with those most poorly affected, and I think really just it's a question. I would like us to be more fully involved from a housing perspective in relation to this, and it's a question of how can we help really, because we would like to. A couple of quick case studies. One on the sort of softer skills that we provide, and one on capital measures. The first one on the softer skills is this lady, a Shropshire resident, a carer for her late husband, now caring for her terminally ill son. Home is heated with a combination of electricity, prepayment, solid fuel, and they're struggling. So when we hear those considerations, we know it's going to be difficult. So we're able to provide a home visit, some energy vouchers, some low-cost energy efficiency measures. We did a tariff check. We signed her up for the Priority Services Register, which is effectively a VIP list in the event of a power cut. Some low wattage heat seaters, delivery of coal, and we were able to use the crisis funds that we've got quite creatively to provide her with a coal trolley because she's got a poor shoulder. So just some examples there of what we were able to do for her. Looking more at the capital funding side of things, this is a couple just outside Bridge North, Stone Cottage, private landlord, always conditions for complexity in relation to cold homes. He came to us as a cancer patient at the time. He is now recovering, but his words were, last winter, we can't face another winter. Solid fuel heating system. So in terms of the capital programs that we've got access to, which are really working with private sector housing and others, we sought to bring in an air source heat pump to provide first time central heating. We looked at internal wall insulation under a different program. So we've got two funds, two different contractors. So these conversations are taking place February, March earlier this year. The internal wall insulation finally got finished about 2 weeks ago, which is wonderful, but it's taken at least 6 months to get sorted. We got to do the insulation before we do the heat pump, and because of the longevity of that, the funding stream for the heat pump has changed and the installer has changed. So I just use this to illustrate that we can and we are helping, but there is a horrible wicked complexity around some of these funding programs that we seek to engage with. Expert witnesses, I have got a little video I was going to show you. It's only a minute, but I don't feel technically savvy enough that it's going to work without completely mucking everything up. So I'm just going to talk about it briefly. Lucy, top right hand corner, her husband has COPD, and the mould upstairs at home was so poor in North Shropshire that he was sleeping on the sofa downstairs to make sure he got a decent night's kip. We were able, with the funding programme we've got, to put this funny looking thing in here, which is a heat recovery system. So we were able to install two, one in the bathroom, one in the kitchen, and as a result of that, then the husband's breathing issues were fixed. Well, not clinically, but she is saying that he was able to sleep upstairs at night because the mold and the damp had been reduced, very, very dramatically. So, that's one small example, but a really interesting witness of things that can be done to be improving COPD and respiratory issues in cold homes. Bottom left is a wonderful lady who was a tenant of a Shropshire Housing Association, I won't say who in her 70s lived in a sheltered housing scheme. And whose health deteriorated as a result of being there. It's not good. So next steps. So we're looking at some energy diaries, because one of the things that Susan says is that with the storage heaters that she had, the indoor air temperature is dropping to 10 to 15 degrees at night. So we want to work with her and people like her to try and gather some evidence over the winter to understand, what is the indoor air temperature? Is your heating working? How are you feeling? So that's the next step for us. Another step is around just developing health relationships. So we did a fuel poverty conference a couple of weeks ago, and Dr. Fahim Murtaza from Public Health came along. We spoke to his boss, Zoid, on the back of that. Briefly.
Sorry. Yeah, because it is just coming up to 11 o'clock now. So maybe you could.
To be honest, I'm about done. So we've got some funding programs, lots of opportunity. It'd be great to kind of just explore how we might take some of these forward. And I'm sorry for the emotion. So over to the 1 minute silence. Thank you.
Thank you very much. Right, 11 o'clock, so. Thank you. Simon, thank you very much for that presentation, and I'm sorry I had to interrupt you just towards the very end there, but well timed. Do we have any questions at all? Yes, Claire.
Thank you, Simon, for a really emotional presentation, actually, and don't apologise for getting emotional about giving it. Just an offer, really, as CCG Director of Partnerships, really happy to have a conversation outside of this meeting to see how we can link you up to the right people and get involved in some of this work. It's really interesting, and it's very pertinent to the work that we're doing around primary care and community care as well, and some of the place-based work. So just giving that offer, really.
Wonderful. Thank you very much indeed. I really appreciate that.
Laura, LF.
Thank you, Chair. Yeah, it was just to say I was going to say exactly the same thing, Claire. Don't ever apologise for being passionate about what you do, Simon. Absolutely not. So yeah, I just want to say, you know, you're doing some brilliant work with the private sector housing team. You know, Tim and Ollie regularly update me on the work that you're doing, and it is absolutely excellent. I just wanted to also comment on the additional funding that we're putting in around the household support fund, so specific funding around people's bills. So although a lot of the work that you do is around the heating and the fuel poverty, there's also some support going in for families and individuals around specifically being able to afford their bills over the coming winter. So just wanted to pick that up after Penny had mentioned about the household support fund earlier.
Thank you. Are there any other comments at all? Right, well, thank you, Simon, very much for that presentation. Thank you very much indeed.
Thank you for the opportunity.
Move on to now the trauma-informed approach and resilience workshop update. Val.
Yeah, thank you, Simon. Hello, everyone. I just want to give an update on the trauma-informed workshops which took place at the end of September, beginning of October 21. These were put on for Health and Wellbeing Board and Shropshire Integrated Place Partnership members, and we had a good response, and the workshops generated so much discussion and interest, and you know, emails have come in through since with people really thinking, right, this is what we really want to do. I can't describe the sort of enthusiasm that this has generated. It's just magnificent to see. So what happened was we had a workshop which consisted of a screening of a powerful film called Resilience, the biology of stress and science of hope, and then we had facilitated discussion following that. So I'm not going to go into adverse childhood experiences, or ACEs for short, in detail, because a lot of that is detailed in the paper. But in summary, these refer to some of the most intensive and frequently occurring sources of stress that children may suffer in early life. And it's been evidenced that considerable and prolonged stress in childhood has lifelong consequences for a person's health and well-being. So this is a life course effect on people's health. So although it comes under the priority of children and young people for the Health and Wellbeing Board, it crosses over so many more. There are the known physical effects as well as emotional effects of the body are described really well by a couple of the people who've implemented this approach in the film. One of whom says, Dr. Victor Carrion is called, describes the effect as if all day long you feel like a truck is coming at you day after day after day, that's going to take a toll on the body. And Dr. Nadine Burke-Harris, who again is one of the pioneers of the approach, said how exposure to early adversity and trauma literally affects the structure and function of children's developing brains. And I guess, the film's a tough watch at times, but we also saw the hope and the great work that was happening in the United States which is where the film was based, although it's, as I'll explain in a minute, it is happening in the UK. And they showed the resilience work that they were doing with families and children. And this builds the ability to thrive, adapt and cope despite tough and stressful times, and is a natural counterweight to ACEs. So work happening in the UK, there's a lot of work happening in Scotland and Wales, and Manchester City Council is another example where their population health team is leading work to fulfil the ambition of Manchester being an ACE-aware, trauma-informed and trauma-responsive city by 2025. There's lots of interesting stuff out there on, YouTube clips, etc., where people are talking about the work they're doing, and they want a coordinated approach to reducing exposure to ACEs and working in a trauma responsive way. And this is really our ambition for Shropshire. I don't think we can stop harnessing this enthusiasm. I mean, as I said, workshops that people have come forward since the workshop to say about how they would like to implement in their settings. But what is really needed is a commitment to resource, which we've put in the recommendations from all system partners. So it's more than us all, agreeing with the approach. It's right, what are we going to do? What can we do next? If we want to create a trauma-informed workforce. The system resource coming together is absolutely crucial. And I think from the workshops, that desire to genuinely make a change was demonstrated through that. So I just want to finish with the words from one of our participants at the workshop. I don't know who it was, so you may recognise your words here. Implementing ACEs work can be a chance for the system to prove it's the right thing to do. If people can see a concerted joint up approach to identify children or adults with a big history of trauma and provide resilience training and support to them, that would be tremendous. So that's really, I've put the recommendations in the report, and really a lot of that is around resource, as well as monetary, as well as commitment to staff being involved to move this forward. We have got a small group at the moment, but obviously that needs developing with a specific coordination post. Thank you.
Yeah, Tanya.
Thank you, Val. So I was at the video show. I have to say it was a very powerful show. So thank you very much for coordinating that, Val. I guess my comments to the board would be the system can't afford not to take this approach on. I am interested though, Val, to understand what is the commitment you're actually asking this particular board to commit to. I noticed in the section 5 financial implications you refer to 100,000. Is that to the Shropshire system, or is that across Shropshire, Telford and Wrekin? Thank you.
Yeah, that would be, well, at this stage, Shropshire. I mean, obviously, if we roll it out further, I think we would need to join together more with that. But and I have to say that figure was something put together very quickly, so it is a real sort of estimate at the moment. But yeah, that is probably a Shropshire figure, but saying that, if we talk about coordinating as a system, perhaps we need to have that wider conversation. I hope that answers your question, Tanya.
It does, just to make it clear for this board that whilst we can make a recommendation, we've not got the authority to agree resources, so we need to agree steps forward in terms of how we take this forward as a system in terms of our recommendation.
Thanks, and I think that the plan would be to go back to the Joint Commissioning Board and looking at Penny, because I think that the plan is that would where it would go, is where it would go if we can get the words out. Thank you.
Yeah, I've got Penny and then I've got Mark. So Penny.
Thanks. Just to comment on that, so I think the resource for the system, and when we say system, I think we are talking Shropshire system, is around commitment from individual organisations to that in-kind support, that idea that all of our workforce should understand trauma and take a trauma-informed and take part in the training. So it's beyond, so there is this kind of aspect, actually, to make it happen, we need somebody behind it, driving it, coordinating it, making it available, pulling together the training and really flagging it up to all our organisations. But then, so there's an ask for commitment to have that coordinated support, and then there's an ask also for organisations to say, yes, please, we want our workforce to be trauma informed. We want to take this approach, and we recognise it as a need for public health. Otherwise, it is, I think, as you would have seen in the screening, it is the biggest public health concern that we've got going on at the moment, and it links to inequalities and healthy weight and healthy heart and a whole range of health conditions. So for me, it's a no-brainer. But obviously, in a system where we're struggling to find funding, it's another pressure.
Mark.
Yeah, thank you. I was going to comment on the recommendations rather than on the paper. So, paper's great, very supportive. At 2 points. From an NHS point of view, we can't say system if we don't include Telford and Wrekin. It's otherwise it's Shropshire. There's nothing wrong with that because we do some stuff just with Telford and Wrekin too. However, in knowing the leadership of Telford and Wrekin around this kind of issue, I think it would be a shame if we didn't take the opportunity to try and join it up. So my thought would be, let's pursue that conversation, not least because actually it makes the resource stretch further, which is my second point, which is we wouldn't be in a position today, Chair, to accept a recommendation that implies that money was there to fund this. I think that's my slight worry around the recommendation, the way they're phrased. What we'd be happy to do is to support in principle the direction of the paper. I think the approach and the trauma-informed approach is very much part of what we like to do. But I do think, I'm afraid, we need further conversations about how we resource this. As Penny just said, unfortunately, we're in a situation where we don't have spare cash, and we need to consider it alongside the other priorities. So work through how we can do that together. So that would be the suggestion from me. Hopefully that's helpful.
That is helpful, thanks Mark, and certainly yes, that Telford and Wrekin conversation, I take that on board, and also the in principle on
Lynn.
I just wanted to ask if we know what work is already being done within the trauma-informed approach across our system and providers, because I would imagine that there is already something happening, and so it would be really helpful to understand where we're at this moment in time, so we know where we need to get to.
Yeah, I agree, Lynn, and that we know we had the educational psychology team did a presentation at the end about the work that they were doing. But I agree with, I think that would be part of the work that would need to happen, is that we need to see what is happening, so we're not duplicating and using use of the resources that are already there. But I think there is so much more to do. Yeah.
Yes, Penny again.
Thank you. Just to come back on that, so I think there is work going on, and we do have some training packages. So I think part of the kind of what we've started to call the steering group around this is about understanding what we've got. But I think it's whatever we've got is tinkering at the edges. It's not, we don't have anywhere doing a whole scale approach like this where there's buy-in across the organisations. So I think this work is really vitally important to make it happen.
All right, thank you. So we have the recommendations, and obviously Mark's comment with regards to in principle, which you're happy to actually take those. So the recommendations then would be a commitment in principle to resource. Is that enough, or just?
Could we phrase it that a commitment in principle to explore the resource?
Yes.
I don't want to be duplicitous. So
no,
hopefully that's helpful.
Yeah. So with that amendment, and also from approach, and obviously pick up in there about working with Telford and Wrekin.
Yeah, I'll make a note of that. Yeah. And that'll be sorry. And that will be noted in the minutes that Michelle does as well. Anyway, went to Michelle. Yeah.
Okay, so we're happy then with the recommendations with those amendments. I'll move them. Are they seconded? Yeah, all in favour. Great, thank you very much indeed. Right, thank you for that. So we'll now move on to the West Midlands Ambulance Service Annual Report. Vivek Kashu. Vivek, you there, are you? Yeah, great. Right,
Okay.
well,
Thank you.
right, if I can ask you to present your report, thank you.
Well, just a couple of opening words. I guess I mean, had it not been for other things happening, I would have presented this report some months ago to the board. So this is I'll go through a set of slides which just take people through last year, because it's an annual report reflecting back. I'll draw where relevant the kind of where things have changed, because where we are right now is a very different place to where we were at the end of last year. So where I can, I'll just draw out where things have moved on, because just to make it sort of current and relevant for colleagues. Councillor Jones, just give me an idea of how much time I've got.
We've actually allowed you 15 minutes.
Oh.
So you've got to speak very quickly. Now, obviously, if there is a slight overrun, we're already sort of 15 minutes over our allotted time. So let's say
that's fine. Let me just, no problem. Let me just get my slide up. Bear with me, I think it's just taking a moment to just turn the cog.
We can see it, the slides, we can see them.
It's just taking a while just to go to slideshow for some reason. Can Brenda see that?
Yes, sir. Yeah,
okay.
That's fine.
Great, thank you. So this was actually, I've trimmed a little bit, but a set of slides that our Chief Exec gave to our Council of Governors, just to set out the kind of year that was in our annual report, really. So I'll canter through these and leave some time for questions or queries at the end, of course. So one of the big things we did last year was to redo our organisation strategy. So we refreshed our 5-year strategy, which also included vision, objectives and values. So the vision, you can see we reaffirmed, this was actually what we previously subscribed to, but we reaffirmed it, because for us, getting patients into the right place at the right time is absolutely where we still need to be, and it's something that we've been redoubling our efforts on ever more so, particularly over the course of the last year, 18 months. So for us, that was very much where we still needed to be in terms of vision. By way of value, we added an additional value, which was around environmental sustainability. So for us, I mean, we cover 17 million miles a year on the road with our fleet. We've got infrastructure literally covering 5,500 square miles. So for us, our carbon footprint and our sense of responsibility to the environment was an important thing for us to do. And I'll come on to some of the things we've done around that, which have been really good, actually, for us as an organisation and for the ambulance sector as a whole. And you can see we've got 5 strategic objectives. Nothing kind of out of the ordinary. You'd expect us to be focusing on the 5 that you can see here, and why wouldn't we? You know, they are the right things for us to be in. So in terms of integrated care system, that's a new place for us, and it's an interesting place for an ambulance trust, because we've got 6 to work with across our region, and if we were the North East Ambulance Service, we'd have 1. But part of my role, and the reason my role was established, and it's a new role to the board, so I've been with the trust for a year, is to do more around engagement and partnership working, because clearly we see that there's the NHS with partners, local authorities and so on are moving very much in that direction. We need to do that. That's a challenge for us. Because clearly, as I said, we've got 6 ICSs to work with. Underneath that are a much greater number of places, and there's already a conversation earlier in the meeting about neighbourhood and what does neighbourhood mean. Of course, we need to be part of a conversation which kind of covers all of those literally all of those places. And you can see some of the work that we've been doing. So on our strategy, well, we consulted with our 6 ICSs around that. Our Chief Exec and Chair have been engaged with their counterparts. We've been asked, so Shropshire colleagues asked us to comment, for example, on the ICS strategy, and we participated and actively gave our thoughts. And also key, the other thing we've been leading on as a as a sector, but also as an ambulance trust, is how do we get commission going forwards, because that's clearly an area of change, and there's progress around that. So a lot of change, but us also trying to adapt to the change in terms of the landscape we're in around integrated care systems. A little bit here, won't spend too long on it, but it's just to set out what we are about. And clearly people appreciate things like NHS 111, people appreciate the yellow ambulances they see on the road or ringing 999, but there's a lot more to us than that. And hopefully this slide just gives people a bit of a flavour as to what that actually looks like, some of the kind of constituent bits within our organisation, because it isn't literally all just about ambulances, there's quite a bit more there. So with CQC rated outstanding, we're proud of that. This also talks about soft segmentation. So NHS bodies are rated against the single oversight framework. This says segmentation level 1. Actually, we've been moved to level 2 within the segmentation framework. That occurred last month. Main reason why we'll perhaps come on later in the meeting to some of the pressures that we're now dealing with, but we're in a very different place now when it comes to pressures, response times, and everything that falls from it, and that's been recognised in the oversight framework now for us. So at the time of doing this, yes, we were segmentation level 1 in the framework. Now we're segmentation level 2. A little bit around COVID. So the top chart here, it sets out kind of the beginning of the pandemic really, and you can see kind of March and April what started to happen with things like 111 calls. And 111 for us has been an interesting experience, because at the time of taking 111 on, which was November 19, we planned on taking 1.2 million calls. You know, we roll the year on and we're closer to 2 million calls. So patterns of behaviour when it comes to utilisation of health and care have really changed and swung quite significantly over the last 18 months. And you can see some of that there. Around just on the bottom chart, you can see where we've categorised the calls as being potentially COVID. Now, it doesn't. It's what we believe to be potentially COVID. It doesn't mean they had COVID, and it doesn't necessarily reflect, you know, the testing data that you would see in hospitals when we would convey patients. But just for the board's wider benefit, we're on our 3rd, so we look at it every month. And October in succession has now been. There's been an incremental growth in COVID-like presentations to our services, and that was the 3rd consecutive month. So now it's at around about 11% of our workload is potentially COVID related now, and it's been growing month on month for the last 3 months by about a percentage point each time. I won't go through all this, a lot of information here, but it just sets out our response to COVID at the beginning. But now we're 18 months on, what felt like us, like all of the health and care colleagues were doing, a huge response, you know, getting ourselves on a footing like we've never been before. We're 18 months on and still living with much of this. So whilst at the time this was undertaken on the basis of being actually a critical incident, now there's so much of this which is essentially just sustained as business as usual. So at the time we of course hoped that we would get to some sort of sense of normality, but I don't like to use the term living with COVID. Personally, I don't like to use it, but it's certainly here at the minute, and it's certainly here medium term. And a lot of the things that you can see here, we've just had to sustain as business as usual. Again, I mean, this is just an extension of the slide you can see, so hopefully just gives colleagues a sense of all of the additional measures that we took for ourselves to protect our patients, our organisation, our staff during all of this. And no doubt if Shropshire colleagues, as in Shrewsbury and Telford colleagues, were here, or Shropshire community, they would have a similar list of extraordinary measures and efforts that they took too. We know that COVID also presented a particular challenge to our colleagues from ethnic minority groups. So I'm our COVID incident director. I also lead our vaccination programme too within the ambulance service. And it's just to give colleagues a sense of, we took particular focus and attention on our colleagues from ethnic minorities, because we knew, as we do now, and the evidence is overwhelming about the disproportionate impact it's had on those groups, not only just staff, but of course population at large. I'll perhaps skip through this because some of this is quite old in essence, because I say we're looking back, but there were some things that were worthy of note, I think. So we've had some incredible support from University Hospitals Birmingham, because you think we've got 7,500 staff members spread across the whole of the West Midlands. We don't do our own testing, as in PCR type testing. We don't have our own laboratories like a hospital does. So the NHS really did rally around one another to support each other, and we had some great support, say for example in that instance from University Hospitals Birmingham. Tried to put in and did put in a lot of extra effort around mental health, well-being of our staff, vaccination, testing. We've got our own in-house testing and tracking process. So really did as much as we possibly could do around it. Vaccination, so there's a bit of talk earlier about vaccination. So as an organisation, our staff, we're at 91% vaccination. We've been affected by the recent guidance on two fronts. So the original consultation around care home staff affected us because we have PTS, patient transport, and patient transport were encapsulated within that, because of course our staff couldn't go to care homes and other sorts of homes if they weren't doubly vaccinated as of today. You know, I think it went live today. So we had to ensure that all of our staff from PTS perspective were vaccinated. And then like the rest of the NHS, who are, I mean, the term's frontline, but essentially patient-facing staff in the NHS. We heard the announcement in Parliament today, didn't we? The other day from the Secretary of State. For us, you know, we've got a contingent of staff who are patient-facing, who aren't vaccinated, around 275 actually in total, that we'll now need to work with to be compliant with it by April. Call answering, big thing for us around 999. So call answering is something we're quite proud of, because even now, despite some of the real challenges we've had, our call answering performance is by a country mile better than our peers. So there's you can see 10 ambulance trusts in the country. If I was to give you last month's data, for example, this currently is that, you know, we are a country mile better. We've had our own difficulties. It has been difficult, but it's something we absolutely focus on relentlessly from the chief exec down, that we must get our 999 calls answered in a timely fashion. You can see some of the variation here on this slide about how we're framed versus our peer group. This is an interesting one. So last year, despite a really difficult winter, we managed to finish the year having achieved all of our response time standards. I'm really, really proud of that. And why wouldn't we be? You know, we're the only trust out of 10 that's actually delivered on all of its response times for the whole year. That won't be the case this year. That will not be the case this year. So if I'm back here next year, I won't be giving the same situation. Our performance standards, our performance and response times have deteriorated considerably during the course of this year, primarily from sort of June onwards, really. We'll perhaps come back to some of the issues that are related to that. And it's not going to be possible for us to recover them by the end of the year either. Now things are actually getting harder and harder as each month passes. We've got a winter to face. We won't be recovering the situation that we've got now. Having said that, as I just mentioned, call pickup times are still absolutely best in the country. Our response times for us have been a big deterioration. The country's deteriorated, but actually as an ambulance trust, we're still are in the top sort of top two of performers, but actually still not meeting the response standards and not where we want to be. Again, this is just a bit of a run through of some of the response times. So here's Cat 1, Cat 2, Cat 3, Cat 4. So those are the kind of 4 categories of calls we deal with. You can see where we were last year in terms of our performance against the national benchmarks. And again, as I say, we were really proud of that, but I can't say the same at the minute now. Conveyance rates is something we work really hard on, and we've made some real changes even during the course of this year. So even despite all of the real difficulty that we've had around pressures, handover delays, demand and so on, we've still managed to progress this area relatively well. So you can see during the course of last year how we were doing around conveyance rates, non-conveyance. If I could just draw your attention to the bottom left, so hear and treat. We instituted a change in the last week of July this year around hear and treat. So what previously, once calls were categorised according to category 1, 2, 3, 4, ambulances would be dispatched. Now for category 3 and 4, we have a group of clinicians who, prior to ambulance dispatch, speak to the patient. So we call the patients. The clinician speaks to the patient or the caller to just ascertain what their needs are, you know, what's actually going on, and to see how we could better meet their needs, which may actually still mean an ambulance, but actually not always. So our hear and treat rate now is much closer to 20%, not before, and that was quite a radical change in how we deliver our operating model. So the bottom line benefit though, so there's much more hear and treat now taking place than there ever has been, but see and treat has reduced a little bit on the back of that. But the main thing for us as a health and care system, not just Shropshire but across the whole region, of course, is that we're also taking fewer patients to hospital as a result of that. So across our region, less than half of our patients who ring 999 actually end up going to hospital, and that's a continual focus area for us. It's not, by no means have we finished there. We've still got much more to do with colleagues and partners. This is an interesting chart because you can see what lost hours in terms of hospital handovers have been like. You could see the trajectory we started on in terms of 21-22. I said we started to lose our performance around June, and you can see June was effectively the same. June of this year to us was like December. You can see June was a winter. It shouldn't have been, but it was. If I was to extrapolate that line to October, it wouldn't be saying 8,000 hours, it'd be saying 28,000 hours across the region. And that's the scale of the problem we now face. It's extraordinary and unprecedented in nature. So though you can see a problem there, as I say, October it's 28,000. It's off this chart. PTS, we provide a lot of PTS across the, not across the whole of the West Midlands. We're not the universal provider of it, but where we do provide patient transport, you can see a lot of information here, but I guess it's just to convey to the board where we do provide PTS, and you can see in the Northwest, Black Country, Birmingham, Sandwell, Wolverhampton, Dudley. We absolutely meet all of our KPIs with regard to PTS, and that's been a difficult challenge too, because of course things like social distancing on PTS vehicles, for example, hasn't been easy to manage. Before, when you could see the PTS vehicles and you could have a number of patients within each one, the impact it's had on productivity was quite profound to us. So this is for us a matter of great pride that we've managed to still maintain our performance despite the challenges COVID brought specifically to PTS. Okay, well, let's get through that. That's more PTS. So quality account. These you can see what our priorities were for 2021 with regard to the quality account. We recently obviously we refreshed the quality account for this year. A lot of engagement took place on that, so we had events open for colleagues to comment from ICSs, place, took on board all sorts of feedback in development of our quality account too. So you can see how we fared against the priorities that we had. That slide. Complaints for last year. Arising complaints, as you can see, an incremental increase in the numbers of compliments too. Like a lot of other people, a lot of our compliments actually start to come through social media now, as much as a formal sort of letter writing, but that's all fine too. We're very grateful to it. We're very grateful for the ones that we do receive. So that's just a statement there around complaints and compliments. In taking on 111, that's a big kind of strategic move for us because it was really part of our own integration journey and how we go about integrating 999 and 111 together. So they share a common platform. Our staff are dual trained. We're able to move our staff between the two depending on call volumes and pressures. The staff are literally located together. So if you were to take a trip to Dudley and Briley Hill, you'll see our what we call emergency ops centre. The staff literally are located together. And for us, that's been a real benefit during COVID, particularly because of course it enabled us to have a resilient service. As I say, that was not just resilient, but was able to support one another, which is, I think, during COVID, a real plus point around organisational resilience and stability in critical services. I mean, for us, it's an ongoing story, really. So this year we've with the support of the 6 ICSs, we're investing heavily again in 111, because you'll remember the comment I just made about 111 demand. It rapidly outstripped what we signed up to with our commissioner. So we had what we thought to be between us all a very realistic expectation of activity, but 111 completely changed. You know, it just radically changed the way, not just in demand side terms, but also the profile of calls. So before 111 originally was almost like an out of hours service, actually, because the in hours work was effectively done by primary care. Our 111 activity is really flipped now, so our demand is much greater as first thing in the morning, and it kind of mirrors primary care. So it's been a total change in also how we'd have to deliver it. So we've got a significant business case underway. We've already started to recruit with a lot of additional colleagues coming into the 111 service that we now provide currently for the whole of the West Midlands, with the exception of Staffordshire and Stoke-on-Trent. Health and wellbeing of our staff has been a big area for us. I won't go obviously through each of these bullet points, but we've put in a tremendous effort around health and wellbeing because it's affected our staff like it's affected lots of other colleagues too, and we knew it had to be a priority for us, like it has been for many others. So hopefully this gives you a sense of the effort we've gone into around the health and wellbeing of our colleagues, and in our recent board meeting, literally just now, we just signed off a refreshed strategy for health and wellbeing and workforce too. Sickness, well, I don't want to jinx anything, but I am sat on a wooden desk. So sickness at the moment for us as an ambulance trust is relatively okay. I think I won't overstate it more than that. I don't want to jinx where we're up to. We've got some of our peer groups with sickness levels literally twice that of where we're up to. So we're just below 5% at the moment. We've got some ambulance trusts who went to double digits, like where we were, where the ambulance sector was back in January. Sickness at the moment is a major issue. And that's not just specifically COVID related absence. That's not a COVID only matter. I think the NHS is dealing with a workforce that's tired. It's dealing with a workforce that's been incredibly stressed out too over the last 18 months. And our staff aren't so different, but thankfully, between us all managed to maintain a level of sickness that's still manageable, and thankfully in a fairly stable place. Turnover, well, thankfully our staff wish to stay with us, and you can see where we fare against the other ambulance sector, and then you can see in terms of the wider West Midlands and England. So a relatively stable workforce. We're actually a really young workforce. We have got a millennial opportunity or challenge, depending on which way you look at it. You know, our workforce is incredibly young. If you look at the paramedics actually out there on the road, or if you're to look at our staff in control rooms and so on, it's a really young workforce that we actually have. So we're really proud that they're choosing to stay with us, despite all of the pressures that I've just talked to as well. Some awards and recognition along the way last year. You can see the work on wellbeing attracted quite a bit of recognition. HPMA, we were also awarded covenant status for military veterans, and you can see a couple of others there as well. So stuff that we're pretty proud of. Something around equality, diversity and inclusion for us as an organisation. So you can see how we're constituted as a board by way of diversity and inclusion, and our workforce too. Again, something that's a big priority for us in a particular area of effort. We've still got more to do. We serve a really diverse region, of course. The West Midlands is a really diverse region, and we want to, as best as we can, reflect those that we serve. That's better for patients. And we talked about employment opportunities and regeneration too. As an organisation, we've got a budget of around about £400 million that gets largely spent locally. We're part of that. We're part of that too. We've done a lot of work around apprenticeships, cadetships, and things like that locally as well within the West Midlands. So for us, representation, diversity, inclusion, really important. So within the NHS, there are these things called global digital exemplar sites. We're one of them. And you can see some of the things that we've been doing as a result of the investment we had as a GDE site. So EPL just launched a new version that's currently underway. We're pretty much paperless as an organisation now. A lot of other work going on around how we start to use technology to improve patient care and improve pathways. So, for example, just last week in our exec team meeting, we were talking about how do we better utilise other services, how do we create electronic means to literally transfer patients to other services. So, for example, how do we, when we've got patients who could actually benefit from, say, an urgent community response, how do we do that in a really smart way using technology? So those are sort of, you can see some of the areas we're getting into here as a GDE. Right. I've already touched on some of that, so I'll perhaps skip over. The only last thing I might just say at the bottom talks about a rollout of iPads. So we've just literally rolled out, the whole ambulance sector was funded to do this by the centre. So all of our frontline staff have actually got a SIM-enabled iPad. Again, that's really helpful for them around when they're on the road, needing to link to other services, video calls, all sorts of stuff. It's really going to help open up what we're able to do for our staff on a digital perspective, but you can see some of the things there. Yeah, I'll just wrap up briefly. Last couple of comments around fleet. So we've got the youngest ambulance fleet in the country, so that our ambulances aren't any more than 5 years of age. The other thing I'll just say, just going to the environment bit, with your first ambulance trust to actually have an electric ambulance. So we've got 2 ambulances on the road operationally in Birmingham. We've also got some of our rapid response vehicles, which are electric as well. Again, the first out there, so they're under test with us. The Ockenden report, that's obviously important locally. Mark, our director of nursing, he's on the call. We've responded to that too as an ambulance service because we actually deliver quite a few babies, more. I didn't ever quite realise how many until I joined the service. Perhaps I'll pause because kind of 21, 22, that's kind of a conversation that's live now, and perhaps we'll come on to that in the rest of the meeting. So I've just touched on some of the pressures and some of the issues that we've been dealing with. It's perhaps a good moment for me to pause and take any questions if I may at that point, Chair.
Yeah, thank you very much for that. Do we have any questions? No? Right, if I can... Well, I think we're getting feedback at the moment.
That's strange.
No, it's okay now. I can hear myself talking. Right, I just need to say that this report is the West Midlands Ambulance Service annual report, and it's for the board to note. But I would, however, move that the board do make a recommendation alongside noting the report. It is disappointing that the report does not contain more details on performance at a local level, the performance of the service specifically across Shropshire, and the outcomes for our patients. As you note in the report, Shropshire, Telford and Wrekin and CCG are one of the 20 commissioners for the service. However, data is not present even at this level. In addition, as you write, your service is located in the heart of England, covering an area of over 5,000 square miles, of which 80% is rural landscape. It would therefore be expected that there would be variations across these areas, particularly rural areas such as Shropshire, and transparency around the performance across the county is essential. I would make a recommendation that further data highlighting performance and outcomes of the services across Shropshire compared to peers and variations across the county in performance be brought back to this board and to be presented to our Health and Overview Scrutiny Committee for scrutiny. move that.
I'll second that.
That's seconded. In favour? Thank you. And there are no questions on your report. Thank you. So we received that with that note that I've put onto it. Okay. Thank you very much, Vivek. Right, because of the looking at the time, and I know several people have to go at 12, and we do normally have a half hour after the end of the meeting. What I'm proposing suggests that we defer the JSNA item, which is item 9.
That sounds right.
Sorry?
That sounds right. JSNA.
Yeah, JSNA Strategic Needs Assessment. Okay, so we'll go on to now to item 8, which is Vision for Dementia. Francis Sutherland, Shropshire and Telford, and Rick in CCG, and George Rook. Okay.
Thank you very much. I'm Francis Sutherland. I work for the Shropshire, Telford and Wrekin CCG, and George is here, who is the chair of our steering group. We've been working together for the last 6 months to develop a vision for dementia, to improve the services that we offer, which I now is going to jump about. My sincere apologies. Okay. So we've worked with people living with dementia. We've based a lot of our work on a piece of report that the Health Watch did a couple of years ago, and we brought people together to talk about how we can improve services and support for people living with dementia. So we've now developed a vision statement, which is that people living with dementia and their unpaid carers are enabled to live the lives that they choose that enhance and preserves their well-being. And we've got some principles about how we want to work, and we really want the system to work as a whole so that people do get much better outcomes. I'm going to hand over to George, and George is going to go through elements of the service that we are developing. George, can I hand over to you?
Yeah, thank you, and good morning, everybody. You have a report that was in the papers, which I'm going to use as the basis for what I say. So on page 4 of it, the key elements of the model. So we see, well, I might just preface this by saying this is not a pathway that people just automatically sort of pass down or pass along. It's a box, like a Pandora's box, of services and support which people will dip into as the need arises. Because no two people with dementia have the same symptoms. So everybody's life journey after diagnosis is different. And the model provides for personalised support and care so that those affected by dementia can live as best they can and independently. So, first of all, we say that the general practices are effectively the keystone in this model. And we intend that general practices will be dementia friendly, although we haven't yet defined what we mean by that. And that all staff in general practices will be trained to understand about the effects of dementia, because it's not necessarily true at the moment. Assessment, we would like to rename the memory service. We don't know what the name would be, but dementia is not just about memory. Memory is the best known aspect of it, but it affects any function of the brain. So we would like assessments to be completed within 4 weeks of a referral. And the reason for that is, and it's not hugely different from now. I mean, at the moment, I think the wait is 6 to 7 weeks or something, which is very good in Shropshire compared with the national. But we would like it to be within 4 weeks because it's a very difficult period for the person who is being assessed, having made the decision often to be referred for assessment. It can be a very trying time, so we want that to be quick. And we want, when the diagnosis is delivered, we want it face to face, not please over the phone. We want it to be in a relaxed, friendly setting rather than a somewhat sterile office. And we want there to be a place afterwards for people to be provided with tea and coffee so they can just take in what they just heard. And we can work to provide people like me who have a diagnosis, who are happy to go and talk to the people after they've been diagnosed to answer some basic questions. We want dementia navigators to be available for every person with a diagnosis. Now, this navigator would be someone who is appropriately trained and would provide local and information and national information at the right times for the person, not just all at once, and appropriate to each individual. They'd meet or speak to the person with dementia and their carer or carers regularly or periodically as the person with dementia wishes. And some won't, but many will. They will accompany or support the person with dementia to access professionals, benefits, social activities, whatever they need, whatever is appropriate, and liaise with professionals in the dementia care system. We wish to expand the current successful Admiral Nurse service in Telford and Wrekin to cover all of Shropshire as well. Admiral nurses are absolutely fantastic. Any person, I know a lot of people around countries, I say countries, United Kingdom. I meet them regularly on Zoom. We talk about stuff about dementia, and Admiral nurses, where people have them, are absolutely wonderful. They're a fantastic resource, providing psychosocial and practical support for family or, for that matter, friendship support groups, because not everybody, about a third of people living with dementia actually live on their own, and therefore they might have a support group which includes their neighbours or friends. We want many people living with dementia in early to middle stages. They find that the real greatest support that they get is from peer support, because in our groups we understand each other. We don't come with preconceptions, and we just talk about it and we help each other. And the people that I know who come to our Riversiders group in Shrewsbury have all said, I have learned so much from you. I have, the world has opened up again. And we find this all over the country through our virtual support groups as well. So what we want is peer support groups, pardon me. And we want one available to everybody. So therefore, we need them in all the market towns across Shropshire, and conceivably more. And we want peer groups across Telford and Wrekin, which obviously is a slightly different configuration, so that everybody has access. And the groups would be facilitated by a paid facilitator, but the facilitation would be making them happen and not dictating what happens at them. The model would be the DEEP model, which is Dementia Empowerment and Engagement Project. The DEEP model, where people with dementia are the people who actually decide what they want to talk about, what they want to do, etc. And that is hugely valuable. The next thing is an annual dementia review in general practice. We want everybody, I mean, they should be getting them anyway, but we want everybody who has a diagnosis to have an annual review with staff, I say appropriate staff in their general practice. It doesn't necessarily have to be a GP, although I'd expect the GP to be involved, but it does need to be with a trained person. and to produce and update a living and care plan for the person, which they will own and which they will carry with them, in a sense, you know, however you define carry. And the annual review might be comprised of several different meetings with different appropriate staff, if necessary. This vision requires information sharing across the whole system, because at the moment it's very fragmented, and we all know this, and we know that that health and care have to improve their communication. So this model commits to finding a joined up information sharing system. There will be a crisis team, as there is now, to provide support for people to keep them at home, whatever their home is, and that it does include care and nursing home. If they are in some sort of medical or, for that matter, mental health crisis. We recognise that healthcare in and possibly social care, I'm not sure, in care homes is not as good as it should be, and indeed is unsatisfactory. So we aim to provide the same levels of appropriate care and support, whatever the setting in which a person lives. And we're going to have to work on that to model what this would look like. We want respite. It's incredibly important for unpaid carers, i.e. family, or for that matter, close friends who spend a lot of time with them. It's incredibly important that they get respite. And it doesn't have to be someone a person with dementia being shipped off to a care home for a week or something. That is probably the least useful, and it's probably the worst for the person with dementia. What we want is the availability of a minimum number of days equivalent each year, and we're suggesting at the moment 20, that people can use as they wish. It might be a regular 2-hour slot on a Thursday afternoon every week, or every fortnight, or whatever. But that carers all say, if they have a regular slot they can look forward to, when they can do whatever they want and recharge their batteries, that is what they need. And we, in terms of carer support, we hope at the moment, and they should be, that every person providing unpaid care for a person with dementia should be registered as a carer with their general practice. And if it's not, it should be. And we want every contact by general practice clinical staff to include an inquiry about their caring role and their health related to that caring, because it's the every contact counts approach to things. Because if you ask someone just in passing, and you go to a GP and say, they say, how are you? And you say, oh, I'm fine. But actually, if you ask them a few times or keep asking them, eventually they'll explain what actually is going on. And many carers try to put up with it and try to keep going until they collapse and break. We need to break that cycle. I think after that, I shall pass back to Francis. Thank you.
Oops, sorry, thank you, George. Yeah, we really brought this to the board. Some of you will have seen this presentation before. I know Lynn has been involved in helping us with the work that we're doing. We really want for this to work, the whole system has to work together. The whole system needs to understand what our vision is and how we're going to implement it. So we're bringing it here to share that with you and to get your commitment to our vision and our new model of care for dementia and the carers of people with dementia.
And can I just say one more thing? And this is really important and inspiring. When implemented, this model will be the best provision in the United Kingdom. I kid you not, no one in this country has this sort of comprehensive model which takes you from cradle to grave, if you like. and provides what you need when you need it. So I think that would be fantastic for Shropshire, Telford and Wrekin to actually be able to claim that first top spot for dementia care and support. The other last thing I wanted to say, sorry, but last means almost last. Could I ask the Health and Wellbeing Board to actually schedule 6 monthly requirements for updates from us, from the implementation steering group? Because if you remember, some of you might remember that about 4 or 5 years ago, I actually, with then sort of commissioner support person, brought a model for dementia care to you then, which had been co-produced, and actually very little happened to that. I know there's real commitment to this model. I know the ICS are committed to it, and I just would like you to provide your support by asking us to come along every 6 months and explain what's happening, so you can hold us to account. Thank you.
All right, thank you very much, Francis and George. Right, we've got a question there. Lynn.
It's not a question, but I fully support George in that request for this board to get regular updates. And I just wanted to comment as well and say well done to Francis, the team and George for getting to this point with this piece of work. And I particularly wanted to mention as well that this is a really good opportunity for us as Health Watch to feed back to the 49 people with dementia and the 49 carers who we spoke to as part of our work on the NHS long-term plan back in 2019, who shared with us what their views were and what their experiences were as people living with dementia, and how that has been used to form this vision and strategy. And I think it's really important as a system that we continue to go back to the people who shared those experiences with us and tell them the impact that has had. And in particular, George, I just wanted to thank him for his relentless determination over the years in getting to this point, and his passion and his patience with the system, because he is a force to be reckoned with, and we have really appreciated working with George on this piece of work. Thank you.
Thank you, Lynn. Are there any other comments or questions?
Just to fully commend the report, and George and Francis have already been to Shropshire Integrated Place Partnership Board. We've already heard this powerful presentation, and SHIP absolutely endorsed the model. So thank you again to George and Francis.
Okay, so the recommendation is that note the key activities to date and comment on this programme of work and the revised model, and obviously to request that we have an update at 6 monthly periods. All those in favour of that? Yeah, that's carried. Thank you. Thank you very much, as I say, George and Francis. Thank you. Now we've obviously delayed the JSNA item, so the next item, which will be the last one before my update, is the COVID-19 verbal update from Rachel. Rachel.
Thank you, Chair. I'll keep this brief, but I think it's really important, and there's just a few sort of key messages I want to pass forward in this update, and we will circulate a paper for the board and to go to the public website as well. So COVID cases remain high in Shropshire. We had over 1,200 cases last week. So we had 1,232 cases in our county. That was that had stayed pretty much the stable from the week previously. So whilst we had the half-term fire break, we could term that, we certainly didn't see rates significantly drop, and in fact just stabilise in Shropshire. Our current rate is 378.6. Which is higher than the West Midlands and higher than the England rate slightly. That was the data on the 4th of November, but I can tell you that figures have started, unfortunately, to climb again. So we're in the last few days. I think a particular concern, just to flag, is that our over 60s rates has started to rise again That's in line, the same across Telford and Wrekin and in line with other areas, but we are slightly above the West Midlands on that rate as well. The good news is that testing rates remain high across the county, so we are identifying people with COVID. But also, unfortunately, the sort of the negative news is that, and the sad news is that we are still seeing deaths across the county, and we had 6 deaths reported in the last week. The other important point that I know has been raised, and partners in the room will have the most up-to-date figures on this, but is our hospital admissions, and we have seen an increase in our hospital admissions, which peaked around the 4th of November with 64 cases in our hospitals. We're around 44 at the moment. As I said, colleagues in the room will probably have more up-to-date figures, but that is still high and is higher than it has been for some time back, and we're looking at figures around March. So again, I think my message is really that COVID hasn't gone away. I know colleagues have talked about living with COVID, and I think I just wanted to be clear with what living with COVID means for me and for everybody. I think living with COVID, as we know, doesn't mean that it's gone away at all. It means that we have to live, and we can live very successfully, I'm sure, without restrictions, and that's what we all want to achieve. But to do that, we need to continue with the wonderful work that we've been doing, and all of our residents across Shropshire have been doing for the last 18 months, nearly 2 years now. So we talked about vaccinations earlier in the meeting and the importance of those for both flu and for COVID, and taking those when they're offered to us. But we also talked about the self-care messages, which are really the hands, face, space, fresh air, minimising contact, thinking about where you're going, and just risk assessing in situations as you go into them. So wearing masks if you're in enclosed spaces is absolutely is critical when there's lots of people around that you wouldn't normally mix with. Assessing those situations that you're going into, making sure you do your testing. All of these, which we absolutely know about and have lived and breathed for the last 18 months, are still as important as ever. And I just ask people and encourage people to really continue with that. It's so important as we go into winter. So our messages over winter really are around keeping those methods in place, really self-care, hands, face, space, fresh air, testing, but also vaccinations, but then also keeping ourselves well and starting to think. We're looking at encouraging people to have good mental health across winter. Really important that we do that. Asking for support where needed for yourself, for family, friends and loved ones, and we've set up support lines to help people across the county. And there's a range of services out there, and we can help you navigate that. So again, that's something that we've launched again, as we've had throughout COVID, just to really reiterate that support's there, and we'll at the moment. And again, obviously keeping active is so important in terms of keeping ourselves healthy. So it really, I just wanted to update you on the situation. Our numbers, to come back to my earlier point, do unfortunately remain high and are starting to go up again. We know that we've got lots of other viruses circulating this winter, and so those important messages around self-care and around vaccinations are absolutely crucial in keeping you safe and helping you live with COVID in our population, but also from those other winter illnesses that we know that we're susceptible to this winter. And I'll just leave that there. Thank you.
Thank you, Rachel, and I hope your PCR test comes back as negative. Right, have we are there any comments at all for Rachel? No. Right, thank you. So we'll now move on to the Chairman's update and close. I've got a few things to mention here. Defibrillators, correspondence from the County Secretary at SALC, which is the Shropshire Association of Local Councils. The motion has been brought forward from our Bridge North and Shifnal Area Committee following discussions at a meeting with Murray McGregor of West Midlands Ambulance Service, when the question was asked as to what PTCs can do, or parish and town councils can do, to support the service. The response was that the best thing local communities can do is to get as many defibs out in the communities and get people properly trained to use them and on CPR. While SALC can send something out to our town and parish councils to encourage them to work with the communities to provide defibs and encourage local residents to have basic training, they have asked that the Health and Wellbeing Board supports this work. And I think there's a note there from your mapping of defibs in communities is being undertaken with SALC and Public Health, whereby gaps will be identified. Yeah, that's right, Simon. We've had that spreadsheet has just come through actually, so we can start that work. Great, that's fine. For pharmacy ownership notifications, I've had correspondence from NHS England, Primary Care Support England, about 4 changes of ownership from Bicton Heath Pharmacy, Radbrook Green Pharmacy, Bishop's Castle Pharmacy and Clibberry Mortimer Pharmacy to Avicenna, is it? Avicenna Retail Limited. The correspondence and report for full reasoning will be placed on the Council's website on the Health and Wellbeing Board Committee pages. Drug and alcohol strategy consultation. The local drug and alcohol strategy will be going out for consultation, building on the work of the previous strategy. It was developed with the key stakeholders pre-COVID. This year it's been revised to account for COVID and undergone a peer review to ensure the priorities are still correct. Members are encouraged to respond to the consultation and an update will be provided at the January board meeting. I'll now ask board members remain for an additional half-hour catch-up. And could I ask those present remain and those online to rejoin by the link provided from Val. Thank you to all those who've been listening in and participating in the meeting today, and I now declare the public meeting closed.
Chairman, I'm so sorry, but I'm going to have to go. I think I warned you yesterday.
Yes, you did indeed. Yeah, and I'm sorry we have overrun. Yeah. Right.